Welcome to AUA Leadership in Business, an official podcast of the American Urological Association.
Welcome to the AUA Leadership in Business podcast, where urologic professionals experience the practical application of business acumen essential for success in today's dynamic professional landscape. I'm Dr. Micheal Darson, and in today's episode, we will discuss physician revenue in a changing healthcare environment. Joining me today for this discussion is Dr. Hunter Wessells, Chair, Department of Urology, University of Washington School of Medicine, and President of UW Physicians, the practice plan for UW Medicine. Welcome, Dr. Wessells.
Great to be here with you, Mike.
Looking forward to this podcast. It's going to be very interesting. Let's go ahead and start with physicians and healthcare expenditures. Physicians play a pivotal role in healthcare expenditures, being responsible for up to 85% of all expenditures. Could you expand on that?
Absolutely. The interesting thing is that physician compensation is not the hugest driver of healthcare expenditures, but it's one that's easier to control because it's specifically around physicians, whereas the other elements are really hard to rein in. And some of those would include length of stay. And physicians have an important role in length of stay. Can we get people out a day earlier? Can we decide on an outpatient medication? And these are a key driver of hospital expense and revenue, obviously because of DRGs. We get one price, whether it's 5 days or 15. And then we, as physicians, also control a lot of the decisions about drugs, around medical devices, and other technology expenditures in the operating room, procedural suites, and elsewhere. And so alignment and agreement on some of these objectives and goals, and maybe gain sharing, is critical. And it might require rethinking of the relationship between hospitals and physicians.
Can you explain to our listeners a little bit more about gain sharing?
Absolutely. I think the idea would be if physicians have 5 different implants in the inventory and they can align around one implant for, let's say, a knee replacement or inflatable penile prosthesis, then the hospital can often drive a much better contract. In that decision, the physician has no stake in the game. By gain sharing, I mean the idea that somehow physicians would receive some incentive for aligning with the hospital, so that if we're saving $20 million, can some benefit derive to the physicians, whether that's incentive pay or more resources for the clinic or, a more efficient operating room.
Yeah, gain sharing has been going on for a while. What do you think the current status of it is in your region?
I think that it's depends on it's institution dependent. Sorry, that there's some that have a much bigger focus on the supply chain, where the physicians really know the cost of the care they're delivering, so they can really participate in that. I mean, other forms of gain sharing are just budgeting for how much work is going to be done, and if you exceed your targets, that you get more. And I think we'll touch on that a little bit when we talk about PSA models, physician support agreements.
Yeah, let's talk about revenue cycle. Many physician groups are transitioning to what you mentioned, physician support agreements or PSA models. There's a potential for a disconnect between revenue cycle, payer mix, and physician status in a system. Can you talk about that?
Yeah, maybe I'll start with the last thing first. The physician status is an interesting thing that is a potential risk of these PSA models, because in most of these models, the physicians are being compensated and incentivized for work RVUs, which may or may not be aligned with the payer mix or the contract. So you could imagine a physician could do a lot of work that may not be as beneficial to the hospital as to the physician if it's in a low reimbursement environment or the cost of care is very high. So I think the risk is we could have physicians being seen as just an expense on the bottom line of the hospital. And there are a couple of things that are going on that could contribute to, I think, better physician standing at the table, so to speak. Really understanding the full picture of the revenue would be important, because if we're just focused on the professional services revenue driven by those PSA, we won't see the larger picture at the hospital level. Another point is that, the cash collections in a PSA model, the cash collections are going to either the hospital system or the practice plan or something like that. And they may not be enough to pay for the PSA. So the hospital will still be looking at the payer mix, the percent commercial insurance, and these will still be main drivers of the financial stability of the organization. One last point about the changing environment. We're all seeing more value-based contracts as opposed to the traditional fee-for-service, and that money doesn't come in associated with a given work RVU. And so it may require a different approach to how that revenue gets incorporated into the health system, and how, again, the physicians are acknowledged for the work they're doing in that area.
Yeah, this is a very complicated topic when you're talking about payer mixes and things like that, because I know regionally, I was in practice in Arizona, much different payer mix, and now I'm in southeastern Louisiana, which is a much different payer mix. So the reimbursement is so complicated with, government payers, private practice payers. It's easy for the physician value to get lost in all of that.
Yeah, I think you said it better than I did. That's that same idea. If we're just seen as an expense, sometimes it's easy to forget that the patients are coming to see us as the urologists, and that we really are a key driver to the success of any health organization.
What are your thoughts on, physicians out there? How do they help keep track of their value?
I think that gets to an idea that I have to create some sort of dashboard for physicians. And I think it's some of the buzzwords that we hear about, like, providing the access. Can we get people in and help? There are huge backlogs, I think, in every healthcare environment. And so if we can try and help get those patients in, and then, of course, patient satisfaction is being measured, and it's still really important. The work RVU, but that's the thing. If that's the only thing we measure, we run the risk of just getting on the hamster wheel. And so that's why the issues of quality, and those are maybe the hardest to measure. I think a lot of health systems have had difficulty incentivizing quality for specialists, particularly surgical specialists. Are we going to incentivize surgical site infection rates? How are we going to find things that are really actionable and meaningful to the docs?
Your idea of a dashboard is very intriguing. I think adding to that, some of the, just from a monetary standpoint, some of the downstream revenue that we're urologists, so let's talk urology, adding that to the dashboard too would be, I think, something very helpful.
Yeah. And, that's a great segue into some of the later conversations, because I don't know that all health systems want to be completely transparent about that.
Yeah, that is a perfect segue. Let's talk about
can I just throw in one more thing about dashboards?
Yeah, for sure.
The other half of the equation on dashboards is we need to make sure that the tools that are necessary for efficient practice are also measured. And in that category, I'd put things like, well, how helpful and efficient is your electronic health record? How many nurses or medical assistants are assigned to you, and how many rooms when you're in clinic? And then, well, how efficient is your contact center at getting patients scheduled? How efficient is your authorization process so that your patients are getting approved and you aren't getting last minute surgical cancellations? And finally, your block time, your OR time, how's the turnover rate? Do things start shutting down at 4 p.m.? There are just so many things that we could measure that really impact our ability to care for patients most effectively.
Yeah, those are critical points. I mean, there are so many factors that influence how efficiently a provider can practice. And we can control some of it, but some of it is controlled by other, a hospital or a health system. So great points. I think you've got a really good idea with this dashboard.
I'll keep you posted, Mike.
All right, sounds good. Well, let's talk about alignment. Physicians working within integrated health systems with hospitals face a number of potential challenges in alignment. Can you expand on that?
Yeah, one of them we already alluded to. It's just that the hospital billings are a much larger share of the overall health system revenue compared to the physician professional services. And that gets back to that point, that are the physicians being properly acknowledged for their work? If you just look at the revenue for the physicians versus the hospital, we're dwarfed. And then the second alignment piece that I think is important is around contracting, because there's contracting for the hospital rates and contracting for the physician rates. And if you're negotiating on both fronts, there may be pressure to reimburse a little bit less for one side than the other. And again, with hospital billings dwarfing the physician revenue, you could see how a health system might make decisions that will, again, make it look like the physician revenue is less important to the system. And then the last thing is just some practical stuff. The revenue cycle, how you actually do the coding and charge capture and all the billing, it's really different on the physician side than the hospital side. Our physician side, it's on a per item thing. You charge for your cysto, you charge for your E&M visit, you charge for your flow rate. Whereas a hospital, it's one episode of care. And so they're billing for everything in that. So if you have the same coders doing both sides of the equation, I think you can really run into some problems with not adequately capturing all the work being done by the physicians.
Well, this is an important topic. What would you advise to residents that are finishing up their training and going out and looking at different potential jobs? How would you advise them to look at these critical issues about their work not being dwarfed by the hospital or hospital system?
I think the most important thing is not necessarily to choose one practice over another because of exactly how their revenue cycle is set up or how their contracting done. It's more, once you pick a great place to work, try and understand the rules of the game so that you understand where you fit into the ecosystem of your own healthcare network, whether it's a university, a large urology group practice, a integrated health system. And then once you understand the rules, then you can seek to advocate. And I think we all need to advocate for our own role in a health system to make sure we're getting the resources we need. Better electronic health records, use of advanced practice providers, scribes, AI, whatever it's going to be.
Mm-hmm. What about established physicians that are out there maybe looking to change gears in their profession? Many of them will have faced some of the things that you talked about and kind of know what they like and don't like. How would you advise them to analyze a system that they're potentially looking at?
Probably to understand what the biggest areas of change are going to be, and how much do you want to tolerate that. I just sort of think about, if we have a physician who's working in the VA system and then they have to transition into the university or a practice system, taking on Epic. Like if you're moving from one Epic environment to another, I think that's pretty straightforward. But if you're moving from, a very unique health record, it can be a massive undertaking and could be a big dissatisfier. And then I think we'll talk at the end about incentivization of physicians. And I think that's the other thing to really understand. What does the organization you're going to value, and how do they try and reinforce those values with the way they compensate you, other ways they incentivize you?
Yeah, it's definitely a complicated world out there, and you've got the residents that are finishing up training. They're looking at things from one perspective. You've got established doctors that are, retiring at a rate never before seen, or looking to change environments. And, as you stated, the EMR is critical. What is the support that they get? What is, like you said, access to scribes, all that stuff that, is important. So,
but maybe underneath it all is, what are the values of the organization, and do they care about their workforce, and are they committed to improving the environment for the workforce? I think coming out of COVID and the massive uptake of the electronic health record, we're still working through a lot of stuff.
Yeah, agree. I think most public policy surveys, one of the highest, factors in burnout is the EMR. So,
yeah.
Well, let's switch gears a little bit and talk about fee for value and fee for service models. There has been an evolution in the marketplace with a growing focus on value-based care and a move towards ultimate capitation of healthcare expenditures. Can you talk about those topics?
Of course, everything goes in cycles, and you might have been practicing early in your career where there were health maintenance organizations that were trying to capitate care, and it's going to be done different this time around, but there's still this need to control cost. I think one of the best insights I've gained in the last couple years is simply to understand that fee for value and fee for service really are, in a way, two sides of the same coin. Value being, cost per quality or something like that. And, whichever system you're in, the cost of care is really important. So if we're in health systems that are having very costly care, we're not going to do well in the fee for value system, where you're getting one payment for a patient's episode of care. But then we'll stop doing well in the fee for service environment, because if our costs are so high, our hospitals and practice plans may not be able to contract with some of the big payers. And so we may lose the ability to maintain some of that fee for service market. What I think is telling is that Medicare is making another foray into, they have the Medicare contracts, of course, but they're even trying to drive some of their traditional fee-for-service Medicare into value-based contracts, not only for primary care, but also for specialties. So for me, the handwriting is on the wall. We need to be really good at delivering efficient, cost-effective care. So whether we're in the value-based market or the fee-for-service market, we can still be successful.
Yeah, as you stated, cost is critical, because that's always a constant in the equation. What's your advice for doctors to, how can they help control cost?
I think it's really hard without having some good data on how much it actually costs to deliver your care. And health systems that really understand that and can deliver that information to the physicians can get some engagement.
Yeah,
our organization is still in an evolution. We're focused on the supply chain and other important things where there's big ticket items. But eventually, we probably need to get down to the individual physician level, so you know that if you make a choice on the suture you use or the device you're using to staple off the hilum of the kidney, that you know where you stand on, are you actually reducing costs for the system or increasing them?
Yeah, I think you touched on what I think is one of the more critical points is physician engagement in the cost analysis is so critical because, we're in the operating room every couple of days or, whatever our schedule is. So we know at a granular level, like how fast you could flip a lithotripsy room versus ureteroscopy versus a laparoscopic case. And our engagement in that analysis is so critical, I think, for a good outcome.
Yeah, we haven't used that term physician engagement. It's often used in other senses, but I totally agree that we can be part of the solution, and we probably have some of the best solutions because we're close to the point of care. And can we align our interests, whether it's through gain sharing or incentives or some other means of making sure that our ideas are heard and implemented?
Yeah, not to mention our quality of life by getting home a couple hours earlier from better turnover of our rooms.
Yeah, that's a form of gain sharing, right? If everyone gets to leave earlier,
yeah, absolutely.
That model works in ambulatory surgery centers for sure.
Yeah, absolutely. So you talked a little bit about capitation, and it will be done differently. You're absolutely right. I'm old enough to remember the early capitation plans in the 2000s. Most of those were unsuccessful, as it basically just shifted the risk. And if the risk was too much for one side, that just collapsed the model. How is it going to be done differently this time?
Well, I think there are going to be different levels of risk and reward. So that's one thing I've seen in some of the CMS work is that they're allowing a couple different glide paths, as it were, so that people can get better at it before they're taking on full risk. So that's one thing that's going to be different. I also think with the electronic health record, we have a lot more data about the acuity of illness and some of those other factors that are so important in these contracts. Your case mix index of how sick your patients are is absolutely critical to whether you're going to do well or do poorly in a value-based contract. So I think some of those things are going to be different this time around.
Yeah, I think with some of the things that you just mentioned, the accuracy of the data is going to be critical. If it's bad data going in, it's going to be bad data going out. We could say it a different way, but just like patient acuity. I mean, that's got to be accurately put into the system, because if you're taking care of a bunch of really sick people, those outcomes are going to be different and more costly, right? So,
yeah. And on the outpatient sort of primary care side, it's the HCC levels that really drive the contracts, and on the inpatient side, it's the case mix index that really drives it. So we have these ways of basically weighing the health of our patient populations.
Yeah, and that is definitely a critical factor. So let's talk about physician incentives. The engagement of physicians in the delivery of quality and cost-effective care is essential. We've touched on it, but can you expand on that?
Well, we've said from the beginning, physicians are integral to decisions about the cost of care. Obviously, their relationship with their patients is maybe the most valuable thing that we bring. And when we start talking about burnout, the frustration of the electronic health record, early retirements, we have to figure out how do we continue to reward physicians for the work they're doing. And there are a couple trends that bear mention. One is that I think a number of health systems and thinkers in this area are moving towards higher base salaries where less of the compensation is driven by actual volume incentives. And that could be healthy if we are really viewed as primarily someone who's totally aligned with what our employer. The time we spend is valuable. That's sort of inherent in the idea that your base salary is a large portion of your total compensation. That whether you're working in an area where there's less work RVUs or it's less efficient to do the work, that you're still valued. I think other aspects of incentives probably can be really influential in recruitment and retention. The call schedule, I think that's been one of the challenges for some of the smaller rural hospitals, and we have a lot of them in the Pacific Northwest where there are just not enough urologists in the call pool anymore. And so it becomes extremely burdensome. Are you on call every other night or every night, or do they bring in locums? And then some of the other things like how much vacation do you get? Do you have access to scribes? So many different aspects of it. And making sure the physician voices are heard in those revisions would seem essential. You know, John McConnell, who's a really esteemed urologist who's led a couple health systems, he put on a pandemic course for the AUA about physician incentives, and it was a really good course. And he put self-actualization very high up as an incentive, the ability to have control over your career and sort of feel like you're doing what you want to do. So all of the leaders hopefully can help their physicians to try and do more of what they want to do.
Yeah, it seems like modern medicine is moving more away from self-actualization than towards it. So I think that being at or near the top of the list is pretty critical and would be unique in today's environment.
I think that gets back to maybe the values of the institution. How do they treat their physicians and the rest of their workforce?
Yeah, we talked a little bit about urologists and burnout. I've always felt like urology is unique from the standpoint that we have more of a longitudinal relationship with our patients than most of the other surgical specialties. And I think that that's one of the things that helps urologists avoid burnout is the fact that, you know, they don't just operate, you know, and I've had, you know, in my practice in Arizona, I had patients, prostate cancer patients, I saw the entire 17 years I was there, you know. How do you think that factors in to the delivery of healthcare, of urology healthcare and physician satisfaction?
I've always felt like those getting to know patients and helping them achieve their goals is really satisfying. It's part of that inherent satisfaction of medicine. And it's unclear whether we're moving towards more of it or less of it. And the electronic health record maybe can sometimes get in the way of some of that longitudinal relationship. It's a great question. I'm not answering it well. It's one of those questions that's not meant to be answered. It's like a riddle.
Well, and I think you touched on it though. It's part of the inherent satisfaction of being a physician, you know, helping people. And we're lucky to have that component of it in our field, I think.
Absolutely. I think that those are the things that keep me going. And it waxes and wanes over the course of your career, but I feel just as invigorated by the patient in front of me as I did earlier in my career.
Yeah, great point. Well, Dr. Wessells, thank you very much for sharing your time and expertise with us today.
Well, thanks for asking some provocative questions and contributing to the conversation, Mike. Really good to make the connection and see where we overlap in our thinking. So I hope this is helpful to our members and that I'll be able to come back and report on other things in the future.
Yeah, I think this is going to be a popular podcast. Thank you. And thank you to our audience for joining us on the AUA Leadership and Business Podcast.
Thank you for listening. If you enjoyed this episode, make AUA Leadership and Business your go-to podcast. Subscribe today by searching AUA Leadership and Business on your favorite podcast app and enhance your leadership and business education needs.